the 10th of September 2020. In an effort to raise suicide awareness and promote an understanding of this phenomenon in Trinidad and Tobago, we, the Trinidad and Tobago Association of Psychologists, decided to launch our mental health platform series to coincide with World Suicide Prevention Day. To this end, we have asked our members to write articles, and we will also be securing interviews and speaking spots on radio and television. Then on World Suicide Prevention Day, members and supporters must light a candle near a window at 8 p.m. in support of suicide prevention and awareness, survivors of suicide, and for the memory of loved, lost ones. Every suicide is a tragedy, and there's usually no single reason someone decides to take his or her own life. We hope that these activities will educate us and effectively help us learn new information about suicide and suicide prevention. Therefore, without much further ado, may I introduce to you Dr. Hazel Othello, Director of the Mental Health Unit at the Ministry of Health, who will say a few words to us. Dr. Othello.
Good afternoon to the executive and members of the Trinidad and Tobago Association of Psychologists, to specially invited guests and well-wishers, and everyone who is participating in today's event. First of all, I want to thank you sincerely for inviting me to be a part of this event, and I really value the fact that you did so. I know that you have a packed program for this afternoon, and I thank you for including me in it. I wish to also offer my sincere congratulations to you as an organization on the launch of your virtual platform. We're in a new era, what we call the new normal, where alternatives to face-to-face contact are becoming the order of the day. So whereas normally you would probably have done this by a conference where we would all meet in the same venue, on this occasion, it has to be done via electronic means. But thankfully we can do that. And I really want to congratulate you on setting up this platform. And I know that it will be used to share a lot of valuable information as you go forward. I also want to congratulate you for the choice of World Suicide Prevention Day as the launch of this platform. It is, World Suicide Prevention Day is a very important day in the mental health calendar, because it is a reminder to all of us of our responsibilities as mental health professionals in terms of doing everything possible to raise awareness about suicide prevention, to assist vulnerable persons as much as we can, and to assist the general public in recognizing risk factors and pointing, whether it's a friend or a relative or a co-worker, whoever they may come into contact with, pointing vulnerable persons in the right direction so that they can get the help that they need in order to reduce the prevalence of suicide in our society. So I would really want to congratulate you, and on behalf of the Ministry of Health, I want to greet you and wish you well in your endeavors as you go forward. I therefore extend best wishes to the Trinidad and Tobago Association of Psychologists. I am sure this platform will enhance the work that you are already doing, because I know that you've been doing some really great work since the onset of this pandemic, and even before that. I think the pandemic just brought what you've been doing to light, but you've been doing great work long before it. So I want to thank you for the great work you've been doing and congratulate you as you move forward in this way. So I want to wish you all the best in your every endeavor, and I know that what you are doing will produce fruit. Thank you.
Thank you very much, Dr. Othello. for your very kind remarks. Thank you. Now, our first speaker is Dr. Karine Clay, PhD. She is the CEO of Higher Potential for Learning, a recognized educational consulting and training organization that provides parents, education professionals, and policymakers with the skills needed to promote a healthy, positive learning culture for all children within their own diverse environments. Dr. Clay is an educational psychologist, organizational health consultant, author, and motivational speaker with a demonstrated ability creating and executing strategies and initiatives to improve psychosocial well-being, organizational culture, program outcomes, and performance of clients. She has done an exemplary job demonstrating her skills and expertise as the keynote speaker and facilitator of many workshops on children in Trinidad and Tobago. Dr. Clay's topic is entitled, The Impact of COVID-19 on Suicide Rates. I now present you Dr. Karine Clay.
Hi, guys.
Hello, Dr. Clay. Hello.
Oh, gosh. I'm so happy to be talking to you guys today. It's been a long journey for me, but I'll get into that a little bit later. I am very happy that we're here today to discuss a really serious and real concern in our society, and that is the impact of COVID-19 pandemic on our already increasing suicide rates across the globe. So I'm gonna drop a few stats on you guys this afternoon. According to the World Health Organization, the last time they did a huge study on suicide was in 2016, where they stated that close to 800,000 people die due to suicide every single year. For every person that commits suicide, there are one or more individuals who attempt to actually, oh, I thought I heard somebody ask a question, sorry. So it was actually one or more people have tried and may have been unsuccessful. And as we now know, anyone just even trying or has attempted suicide is the single most important risk factor for suicide in our general population. Suicide is the third largest cause of death in ages 15 to 19 years old. And during that time, they found out that 79% of global suicides occur in low and middle income countries. It was also surprising some of the common ways that people commit suicide is they ingest pesticides, hanging, firearms, and these are just a few of the common ways an individual actually tries to end their life. So there's very little data currently on the COVID-19 pandemic and its impact on the current suicide rate. We are actually probably another 2 years away from having all the data collected globally. But clearly the pandemic has added intense emotional and mental stress to the lives of people around the world. Even in our profession, we fear that we or our loved ones will get COVID-19. Many of our patients are facing isolation, especially those who live alone or in facilities where they're not allowing any visitors or, family don't really come by as often as they should. Some of us, like myself, live in close quarters with my family, under stay-at-home orders most times, which actually increases the risk of my family and my spouse to getting the disease. Many of us today also worry on how we're going to provide the basic needs for ourselves and our families if we're put out of work for a long period of time or if we lose our jobs. And the biggest impact of, as we know, is to our essential workers. They're constantly in a state of fear and anxiety about the increased risk of COVID-19 that they are actually in every single day. So we know that during the COVID-19 pandemic, many of us without existing mental health conditions may have experienced some overwhelming feelings of anxiety, fear, frustration, sadness, and loneliness, as we all know. But those of us with existing mental health conditions, such as major depression, bipolar disorder, post-traumatic stress disorder, or any anxiety disorder, right? The effects may be worse. And on top of that, they have these additional feelings of hopelessness. I don't know if some of you all recall, what was it? The SARS outbreak of 2013, there was a significant increase in suicide deaths among people aged 65 and over, because the victims felt, or they feared they were going to catch the disease, or they felt like there was going to be a burden to their families. They just had general anxiety because of the social isolation and some of the psychological distress. So I think we can safely predict that the suicide rates may increase along with the prevalence of the psychiatric disorders during and after the COVID-19 pandemic. So, as I stated before, current research has shown that the COVID-19 pandemic has a profound psychological and social effects. We know that it's associated with distress, anxiety, fear of the contagion, okay? So we can all predict from the formal data collected that psychological effects of COVID will probably persist for months and years to come. So we know that there are multiple cases of COVID-19 related suicides in the US, currently in the US, in the UK, Italy, Germany, as well as India, and some other countries that have not yet pulled in their data. So, for example, I've read some data that stated a 19-year-old waitress in England died in a hospital after a suicide attempt because of fears of mental health, because she was in isolation. A 66-year-old man with throat cancer hanged himself in New York City hospital after he tested positive for the coronavirus. A young man in Illinois who was afraid him and his girlfriend were going to catch the disease killed himself and his girlfriend with a gun. And afterwards they found out that they tested negative. So we have so many of these incidents happening across the globe. Also, there has been a huge increase of calls to suicide prevention hotlines in the US and other countries. So some of us know that there are a specific population that is vulnerable. So some of the past and present studies have also helped us to identify within our population who are suicide risks. So in some of the high-income countries, there's a link between suicide and mental disorders, particularly depression and alcohol use disorders. Many suicides happen impulsively, as we know, in moments of crisis, conflict, some disaster, natural or otherwise, violence, abuse, or loss of sense of some sort of isolation that individuals might be going through. So when we think of, it's not just even only that, some people are going through financial problems, relationship breakups, and things like that as well. But I read a recent study when I was actually prepping for this wonderful conversation that we're having today. And it was a study that collected data about over 10,000 people in the United States. And they had to fill out a questionnaire on suicide behaviors questionnaire. It's an actual assessment that's used. And the results of this showed that the majority of the participants, they were pretty much average, which was like a score of 4, right? And that means a low risk range. But 10% of this population scored between 5 and 7. So that means they're a moderate risk, right? And then they said 15% of them scored 7+, which means that this is a high risk. Now, by itself, these numbers may not seem as significant to you. But when I broke it down and I looked at the numbers as far as race is concerned, they stated that Blacks, Native Americans, Hispanics, families with children, unmarried individuals, or those who are not born, and because this was a US study, who were not born in the US, and younger respondents. In this study, they scored higher, meaning 7+, than their Caucasian counterparts. So by far, we all know the strongest risk factor for suicide, like I said, is a previous suicide attempt. But we need to keep in mind as clinicians that there are sometimes existing cultural factors as well as racial factors that may come into play when we are looking at individuals who may commit suicide. So as a clinician, how can we help? So I'll say we need to know what are the unique circumstances of COVID-19. We need to know that there's social interaction that's lacking. We need to know that this is going to be a really difficult time for us to identify some of our patients who have, suicidal ideations, because like now we're not seeing our patients face to face. Some of us may be a little shy about doing telehealth, and even if you're talking to your patients on the telephone, you're like, well, I can't see their faces. I can't see them, avoid eye contact. I can't, or they could just hang up the phone on me. They don't really, have to stay on if they don't want to. And you're absolutely correct. But as clinicians, we need to learn a lot more about suicide prevention techniques, right? So I know all of us are pretty competent in specific areas, but there's so many new approaches and techniques that are actually coming out. We need to be aware of those. We all should be reviewing literature and clinical resources on suicide prevention. I try to make sure that I am up to date on all of the newer approaches to preventing and treating suicide, especially during this uncertain times. So my go-to approach that I usually utilize with any of my patients who have suicidal behavior ideations is cognitive behavior therapy. I also utilize the safety planning intervention and the collaborative assessment and management of suicidality. So I'm going to share that with you guys. I put that, and I'm hitting send in the chat area with some resources that I'm going to speak of a little bit more today, but you guys could look, just like I don't like reading presentations to people. Here I'm giving you where you can find and learn a lot more about these different approaches as well as assessments. I also provide for my patients supplemental support between the therapy sessions that we have, be it weekly or monthly. I offer mindfulness, relaxation, and coping resources. I refer them out if they do not know, because I'm not able to do those sessions with them because that's not my area of expertise. So I refer them out to other resources. A great resource I found was nowmattersnow.org, which is an online place where they have a whole bunch of videos that raise professional and community awareness. We need to screen our patients more. We should be conducting wellness checks by asking our patients in the beginning of every session how they're feeling physically, then transition into checking on their emotional states. We should be conducting screenings in organizations using assessments like the Suicide Behaviors Questionnaire, or my favorite is the Beck Scale for suicide ideation. If you don't know how to use these assessments, reach out to your colleagues, those who already know how to use it, and get trained, because it's extremely important. All of us should already have an action plan, a suicide action plan we should develop for each of our patients, especially during this time. So we should do this, as I would say, as part of your intake. At some point, you should do a suicide safety plan. And what it includes is usually the warning signs or the triggers of a developing crisis, coping strategies, different things the person can do on their own, relaxation techniques and things like that. We need to make sure we know who that person has as a backup, as someone who can be there as a distraction for them. Names of people they can ask for help. or different organizations that are local that the person can have easy access to, you know, or different steps of creating like a hope kit or steps of making their physical environment safer and bringing forth a list of things that makes it worthwhile for them to continue living, you know. So things like that are extremely important as clinicians that we should have. I am so proud of TTAP for what they're doing, because the TTAP crisis intervention team, as well as other members of TTAP in Trinidad and Tobago, have been doing such a great job of raising awareness. And you guys are doing that through social media and online forums just like this, right? So I just want you guys to know, even though I know that you're there taking care of your patients and other individuals that pop into your life, please, in closing, I want to say that the COVID-19 pandemic is just as stressful for practitioners. As a COVID survivor myself, we spend a great deal of time, I know, listening to all of our patients' worries, but we need to follow some of our own advice and definitely make sure we're prioritizing our own self-care. I want you guys to please remember that we're not responsible for preventing someone from taking his or her own life, but our support and our interventions definitely may help the person see that there are other options and that there are other things available to them so that they can stay safe and they can get treatment. I definitely am very happy that I was able to share with you guys today some of the outside resources that you would be able to go in and get some of the information that maybe at this time you don't have as part of your toolkit. But I thank you so much for sharing this little moment with me as far as learning a little bit more about how we can address the needs of our vulnerable population within our patients who feel as though everything, all hope is gone and that taking their life is their only option. So thank you. You're on mute, Wendy.
Muted, right. Thank you. Thank you very much, Dr. Clay.
Yes.
The floor is now open to anybody who wants to ask Dr. Clay any questions. Come on, people. Right.
Hi, Dr. Clay, how are you? It's nice to
How are
see
you
you.
doing, Katush? I know. I'm sitting still, but I'm well.
Glad to see you. So do you think during the pandemic, suicide is more related to being impulsive?
During the pandemic, it may seem as though it is, mainly because, again, people feel as though, oh, I'm going to catch the disease, I'm going to die anyway, or I have no job, I have no place to, so they go straight to the extreme. Many individuals may go straight to the extreme, but remember, some of them already may have a mental disorder. And also because of the pandemic and the psychological impact it's had, those who may have had mild anxiety has now, transitioned into severe anxiety disorders. Many of them, especially within Trinidad and Tobago or most Caribbean countries, you know how they feel about us as psychologists and even going to get treatment from a psychologist or a psychiatrist. So many of them, the signs are already there, right? But some people be like, oh gosh, she just like to be in her room by herself. It's okay. I ain't gonna bother with she. I gonna leave she alone. Or she just one time by she said, oh, leave she now, she funny. And they'll make all these different excuses for the individual. But you, even just regular person every day, you see the signs, but many people wouldn't take the next step to helping that person. So yes, it may seem like it is impulsive or at that moment, but you didn't see all the stuff that was happening. The iceberg underneath the water is much. You didn't see all the things that was happening underneath the water. So that's the reason why I think many people feel as though it's like, it just happened.
Mm-hmm. And can the risk of suicide be inherited?
Suicidal ideations, yes, to some extent, if there's already mental history within the family. So you have to remember, depression, anxiety, those can actually end up being some of the things that are like, that happens as an end result because the person has an anxiety disorder, because they're severely depressed. They don't go through the steps of figuring out, okay, I can cope with this. I could deal with this piece by piece. I could focus on what is in my present box. That problem is in my future box. I don't need to worry about that right now. They don't think that way when they are actually dealing with a mental health obstacle. So you will find that, yes, within our families that we may have depression or anxiety or some other mental health disorder, suicide may end up being one of the consequences of our behavior. And it's not so much that suicide itself is hereditary, it's more the mental illness. And suicide just happens to be one of the choices that that person chooses before coping.
And if you have a patient with suicidal thoughts, how often as a clinician would you meet with that patient, with that client?
I will be meeting with that patient anywhere between twice a week or more if necessary. If you are finding that, like, I have access to my clients via text as well, like I said. So some of my patients who have suicidal ideations, I'm texting with them. So if I'm not speaking to them, I'm texting with them. And when they text me and I see some of the flags of, oh, I need immediately, I call. They don't, when I see the flags, I call. I don't wait for them to call me because I know that at that moment they're on the ledge and I need to talk them back into the room, sit down and get away from the ledge, so to speak. And if that means I have to give them the call, then that's what I do. I give them the call.
Okay, thank you very much.
You're very welcome.
Does
I'd
anybody
like to
else?
make a comment.
Sure.
Question. I'm Jean Alexander Waltran. Dr. Clay,
Yes, ma'am.
would you say that in light of when some of the stay-at-home and lockdown restrictions are made,
Yeah.
that maybe I'm asking because I can't see how the compromise can be made. But however, as you mentioned earlier, that in particular, some persons who live alone and their main way of socializing is maybe when they're at work, when they go to the supermarket and stuff like that. How can we strike a medium in terms of when taking that population of people into consideration in terms of the restriction? I don't know how legally this could be catered for by, I'm an attorney as well. And I'm seeing the side of, okay, the law has to be put in place because it's sort of like just control behavior. Some people are not listening. And that sort of thing. But now when they look at the psychological aspect of it, you say, I tend to think, well, these people maybe, I'm not really thinking about some exceptions for them, but maybe some sort of consideration of how they can be catered for so they're not totally like cut off, because they probably need to some extent this amount of socializing as to not push them over the ledge. Exactly. If you understand what I'm saying.
Yes, I completely understand what you're saying. So I know we have lots of volunteer organizations, right? And so this is just something that some volunteer organizations have done, because the population that you are speaking of, some of them don't have social media. They may not have the internet, and we need to recognize that. Some of them may not even have a phone according to where they are located, or like you say, what age group they may belong to, or if they happen to already have a pre-existing mental health disorder. So some volunteer organizations have been doing things like visiting. You know, they don't visit inside, but they are outside the person's house, like be it on their porch or in the front lawn or something like that. We've had choirs coming and singing, you know, for different parishioners who are not able to go to church, and they're not able to see the church on video or on internet. Some of them will come to the door and do things like that. They will leave tapes with music, or they'll come and sit their chair outside and the person is inside their house, and they might chat with that person for 15 to 20 minutes or whatever the case may be, but they're 6 feet apart. You know, people have come and read to children. That way I've seen teachers, kindergarten teachers, have gone to their different students' homes and sit outside reading stories to the child that's inside, because their parents didn't have internet or whatever the way to be able to contact the child. So those are some thinking out of the box options that we would have. I know that during this time people are afraid, but there are many ways for us to keep checking in on individuals. Even if it's something as simple as making sure every other day we leave a postcard at the person's door, a note, so that they know that they're being cared for, be it a care package or whatever the case may be. You're right, there's a fine line when it comes to legalities. We have to be careful. If the individual refuses because of a mental illness, states, I don't want anybody coming by my door, and they don't want anybody coming around them, that person may actually need outside care, meaning another mental health facility that might have to come in and actually make sure that person's okay. So we have to kind of thread, that fine line very carefully. But there are lots of other ways that you can keep contact. We have to check on these individuals. We have to know that they're safe and that they're okay. Right now, there's so many different phobias that have actually developed, agoraphobia being one of them. People are afraid of going outside, and they're so afraid of the outside coming in. So in those cases, we have to just thread lightly and slowly, but you can still keep in contact and touch base with those people on a daily basis.
Okay, I will have to end this particular session here now. We can go on, and we will, if we have time, after the next speaker. Dr. Clay, let me thank you very much. And particularly the resources that you shared with us.
Thank you.
We are taking note of them. They're very useful. So thank you for now. Ladies and gentlemen, our next speaker is Margaret Nakhid-Chatoor, PhD. She is a psychologist, bereavement counselor, who has worked with families for more than 25 years. She's the immediate past president of the Trinidad and Tobago Association of Psychologists and the director of the MNC Psychological Testing and Counseling Center. Dr. Nakhid-Chatoor is also an assistant professor at the University of Trinidad and Tobago. Her main research areas are the parental bereavement of children and adolescents, grief and loss, schools, and suicide and indigenous Caribbean research methodologies. Dr. Nakhid-Chatoor's topic is entitled Adolescent Parental Bereavement, Risk Factors for Self-Harm and Suicide Ideation. I now present you Dr. Margaret Nakhid-Chatoor. Dr. Chatoor.
Good afternoon, everyone.
Hello, Dr. Chatoor.
Hi, yes, good afternoon. Good to see you all on here. So I'll be going into the third largest group that Dr. Clay mentioned, which is the adolescent group, 15 to 19 years old. My topic is adolescent parental bereavement, risk factors for self-harm and suicide ideation. And I want to look especially at to what extent is the death of a parent a predictor for self-harm and suicide ideation. And when a parent dies, for many persons, grieving is normal, and persons go through a grieving process, 5 stages, which may not necessarily come in that kind of order. But there's denial, isolation, anger, bargaining, telling God, if you bring back the parent, I'll do this, depression, and finally acceptance. So that's normal grief. What I'm looking at this afternoon is complicated grief which is a predictor for hopelessness and also suicide, ideation, self-harm. And this study spanned 3 years, both between New York and Trinidad, but I'll get into that. So some of the triggers for hopelessness and complicated grief when a parent dies are lack of support, an apathetic attitude to life, the death of this major protective factor, an inability sometimes to come to terms with the death, especially if it was a sudden or unexpected death, a violent death, and a kind of loss that not many people are familiar with, an ambiguous loss. That is when there is a death of a parent where there is no closure. For example, a parent who has gone missing, that mother who was taken after dropping off her child at preschool and was never found. What about those children who experience ambiguous loss? How does that trigger all of these feelings? Misunderstandings by adults about the grieving process, a preoccupation with suicide ideation and the self-harm, constant bouts of crying, anger at God, reactive behaviors, withdrawal, and silence. So is there a link between a parent's death and eventual complicated grief and loss and suicide? I was always fascinated by the tragedy of Hamlet. And as you see on the slide, this is 400 years ago. And Ophelia, when she took her life by drowning, was 17 years old. But her death in the literature is romanticized. They thought she was grieving after Hamlet. However, Shakespeare describes her behavior as distracted, as melancholic. Her ladies in waiting describe her as demonstrably insane and mad. They could not understand her behavior after her father died. She was just 17. So she walked into a lake and drowned herself. And that fascinated me because I am looking at now we are 400 years ahead and still adolescent grieving is trivialized. It is not understood by clinicians. And in a society, especially as in the Caribbean, we tend to mask. Some of the characteristics of complicated grief in adolescence are the intense longing, persistent emotions, unable to accept the death, difficulty living, not trusting others, and I saw this come out especially in schools, a detachment from others and constant rumination over the loss. Is it better to end my life? And if we look at the clinical factors associated with suicidality, we would realize that they are more or less the same. There's that emotional distress, a rumination of events surrounding the death, a loss of an attachment figure, compassion fatigue, and we'll see this later on, especially in females who have lost a mother, and it is incumbent upon them in the Caribbean society to take care of their siblings, take care of others. If the family is dysfunctional, this increases suicide risk, substance abuse, and loneliness. So some of the risk factors, as you see in the chart that I put there, of complicated grief, because this is the grief we were looking at, not normal grief. When grief becomes complicated, low social support, an insecure attachment style after the death, loneliness and isolation. Many adolescents go into their shell and you ask them how they're going. And you know, adolescents tend to be very monosyllabic. I'm fine, normal, whatever. And the issues surrounding the death. So these 4 factors, as you see there, are some of the major risk factors leading to suicide ideation. Now, in my study, a lot of the adolescents that I interviewed would be informants or friends of persons who maybe took their life. So there was suicide, and there was also passive suicide ideation. So one girl said that her friend, after the death of his father, her friend wanted to die. He got fed up of all the quarreling, the family dynamics, and he did take his life by hanging. He was just 15. Then there was this girl who dreamt about her mother. And when she dreamt about the mother who had died, she said, I don't want to wake up. I want to continue in that dream with her. I don't want to be part of this life. And I want to carry it right back into Trinidad and Tobago, because it's again, each death of a parent, each death is the loss of a parent who has been a significant figure in an adolescent's life. And as we know, in the past decades, 80% of our persons who have died by homicide, the deaths are drug-related. Adolescent parental bereavement, therefore, mostly fathers, a contributor to the early onset of reactive behaviors, school dropouts, academic failure. And as I said, the parentification of girls, lost childhood, early motherhood. So whether or not the parent is good or bad or indifferent, remember the child or adolescent does not love the parent any less, and a loss has occurred. So the aims of my research were: one, how do we situate grief and loss within our cultural history? What are the responses that our teenagers make in this country with our traditions, our value systems, our rituals, our beliefs? Bereavement as a social justice issue, because as you would see in my findings, many of the educators, and I hope I have some teachers on board here, many of them moved away from social justice issues, and we need to examine student pedagogy in new ways. And we need to move away, thirdly, from grief and loss as being sick. You know, when we see adolescents, we say, oh, sick, give them medication. So we need to move away from this pathology of grief, from medicalizing grief, and situate it within a normative grief framework, because death happens. Children and teenagers need to know how to handle a normative occurrence such as death and loss. And I thought that the Caribbean Yard, as I call it, this research space, was ideal to get a lot of what I needed in my research. Because you know, when adolescents come together, they talk a lot and they're able to relate with their peers. I've always said that as clinicians, we have to be the facilitators on the side, because adolescents and teenagers will talk within their own peer group. So this Caribbean Yard, I said, mouth open, Tory, jump out, because it created a space for them, an opportunity to relearn themselves, to relearn what death meant. And it situated the adolescent within the constructs of his family, school, and community. And I want to go into the research design. So this research took me, as I said, over 3 years between New York and the Trinidad and Tobago. I looked at secondary schools in the East, West, and Central corridors, and I conducted individual and expert interviews. Individuals with school counselors in the school and experts, that's people in the field. One of the leading experts with adolescent grief was a fellow called Professor David Bork. And he lived not too far from where I lived in New York, and he engaged me in this research. Another expert was Dr. Robert Neymeyer. You know that he's the leading research on the meanings that adolescents attach to grief. So we do not have this kind of research in the Caribbean. So if you do not get your research in the Caribbean, you have to go outside for it. You have to find out from people what is happening there and make the dots, connect the dots. Get the information that would allow you to be able to see what is happening in your own space. I also conducted interviews with families and siblings and assessed adolescents for anxiety, depression, etc. Because as you know, when you have conversations with adolescents, in the follow-up, you could have, there could have been a lot of issues that came up that you have to attend to as a clinician on the side. I had follow-up interviews with some of them where this talking about the issues triggered certain anxieties and you had to deal with it. In this kind of research, this was new research, therefore, done in the Caribbean on adolescent grief, never done before. Adolescent voices were heard, and if some of you deal with grief and loss, you will know that a lot of our studies deal with adults who have experienced grief, not children, not adolescents, and we tend sometimes to take the findings of these adults and make interventions for children, make interventions for adolescents, and you know that can be very faulty. The focus group was used for grief studies never done before. So let's look at some of the findings of this research. One, the legacy of the patriarchy in our Caribbean societies continued. That is, when children suffered a loss, they tended to be very reactive, especially males, especially young boys. And instead of understanding this dynamic, instead of linking it to what has happened, many of our teachers, many of our parents punished these behaviors. They saw these behaviors, non-conformist, as deviant, and they used punishment to control the child or get them to sit still in the classroom. Some of these measures were suspensions. There was a young boy whose father died, a policeman who was shot, and he was suspended. The principal told him, shape up or ship out, I'll transfer you. Some would put in detention, in time out. Corporal punishment was used. And for older adolescents, they were embarrassed or humiliated. One respondent says, my little brother does beat up the children when they tell him about his mother dead. Remember, I want you to know, death for little children is a stigma. They do not want people to know that their mother or their father has died. So they get very embarrassed, especially with Mother's Day and Father's Day, when other children are talking about their parents, and they do not want to face this fact because they're not spoken to about it. Another finding was the post-colonial mentalities of schooling, which devalued the grief response. And I found this very interesting for adolescents. Some of the conclusions were that grief was misunderstood. Grieving is trivialized. Many educators thought, what do children know about grieving? What do adolescents know? That is a big people thing. Because of that, it created a culture of silence. Many adolescents put on a mask. They internalized how they felt, and because many of them felt that adults do not understand us. They have to learn how to understand how we feel. I was in class physically, but my mind was elsewhere. And the most important finding for me was the severing of the attachment bond. In many Western research done, they say that grieving begins after the death, but not in this Caribbean society. Before the parent dies, especially if it's an anticipated death, especially if the parent has cancer or some kind of illness, grieving begins. But what I found in the study, which was quite interesting, never saw this dynamic, were children who said, Mommy pushed me away when she started to get sick and she refused to see me. Uncle said, don't come up the hill again to see Granny. Daddy was in the hospital and he told nurses not to let me see him like that. What these adults do is try to shun or to protect children from seeing them in these last stages. But these are the moments when children, especially teenagers, need these last moments to let the parent know that you love them, or let the parent tell them the last words. And in the Caribbean society, instead of this attachment being continued, it was severed before the death. The male response to bereavement, many of them did not want to talk. As one of my expert local persons, Dr. Dylan Kerrigan, an anthropologist who works with males in Laventille and the Beetham, said that many of them put on a mask, a facade of bravado. For young boys, they were physically and verbally abusive. And educators' response to males was, as I said, suspensions, detentions, expulsions in some instances. The female response was quite interesting. The female, if her parent, especially a mother, died, she took it upon herself to be the parentified female. That is, she felt it was her duty to drop out of school and to take care of her siblings. So what is that happening? It means that her girlhood, her teenagehood was interrupted, and a suppression of her voice. Because here it is, she feels that society expects her to leave school and to be caretaker and mother, especially for fathers who could not rally around this death. There was role reversal where she inappropriately met the emotional and physical needs of the parent. So I want to look quickly at risk factors, protective factors. As a clinician, always look at the risk factors when a parent has died. As I said, a history of depression, previous suicide attempt, disconnected from school, quite interesting, emotional immaturity. Instead, put into place protective factors. Look and see if that that individual is resilient, and if not, you need to increase those emotionally resilient skills. School, I think, has become not a secondary socialization factor, but a primary socialization for many students. Strong social skills are built in schools. Empathy, adults who engage in positive health behaviors and pro-social values. At the family level, look at the risk in those families. Is there family isolation, a lack of social support? Is there a family history of mental illness, of abuse, neglect? Because all children, all adolescents need those protective factors if they are to survive. As I said, the attachment bond is important, and the attachments of children and adolescents to significant adult figures in their lives determines the extent to which they are able to give meaning, which they are able to reconstruct this death which has occurred. Because remember, the parent is usually the primary attachment figure in the lives of a child or an adolescent. And when that goes, if we do not talk that child or teenager through, if we do not understand that those family dynamics, it can have serious implications for suicide and self-harm. Emotional intelligence in schools, emotional intelligence training, teaching this in schools so that there's a sense of closeness, reducing the bullying and harassment. Many younger children reported when they were acting out, other children told them, you're behaving like that because your mother dead. And of course, again, further stigmatizing this death. So let's look at the conclusion. Unfortunately, in this society, a culture of silence continues. Evidence points to a risk of social isolation among teenagers over time. And these could lead to criminogenic factors, depression, suicide ideation, aggression. Our governments do not heed the social justice issues of the rights of the child to be listened to be treated with respect when a death happens. So what do? We must look at the issue of complicated grief, as I said before, a family history of depression or suicide, previous attempts, a history of abuse, substance abuse, and ask the questions. Are you having thoughts about hurting yourself? Who would be affected? And this second question really hit home for a lot of teenagers. Who would be affected by your death if you kill yourself? So it gave them a sense of responsibility to the home. We need to promote resilience. We need to ensure that our children and teenagers have protective factors in their lives, receiving effective mental health care, positive connections to their family, having the skills and ability to solve problems and to deal with the issue. So in moving forward, grief speaks a different language for Caribbean adolescents. Adolescent developmental changes affect their meaning making. These adolescents are positioned between childhood and adulthood, identity conflicts, forming identities. What are we saying to them? Interventions need to be reconsidered by grief counselors, and they need to be specific to what we have here in the Caribbean, not adopted or adapted from Western influences or Western understandings of how our children behave. And there needs to be training and development in teacher education in grief to empower, validate, and value the grief responses in our classrooms. Thank you very much. And I'm open to questions.
Dr. Chatoor, I'd like to ask the first one, please. Jean?
Yes, go ahead.
Very interesting research. My question is, did you look at adolescents who their parents were not their primary caretakers and who may have been brought up by grandparents but know of their parents? So there's maybe an absentee father or mother who may have been on drugs and whatnot, dump the kids on the grandparent, but they're very much aware of who their biological parents are. Were these adolescents included? I'm looking at whether that grief and loss is as significant as if it is that they were actually being brought up by their natural parents.
Now, you're looking at the grandparent connection there. In the study, we had some grandparents in the home, and what we saw in the adolescents that I interviewed, the family dynamics in many of these homes were dysfunctional, with grandparents especially. And many of the children, because especially they were not counseled or the grief was stigmatized or ignored, they began to have dysfunctional relationships with those same caregivers who may have been grandparents taking care of them. So again, what we're looking at here in a normal circumstance where there is normal grief, where there are grandparents, it's normalized. You go through the stages, but my study focused on complicated grief, dysfunctional relationships as predictors for self-harm and suicide ideation. And in most of the interviews, that came out. Because remember, these children were referred to me when I was doing this by the principal of the school or by teachers who saw them not functioning, so that they would not have had an issue with children who were normalized or who were coping, etc. Yes. And again, that is a limitation, and that is something possibly for further research. Thank you for the question.
I have a question. Good afternoon, Dr. Chatoor. Deborah here.
Yes, Deborah.
Were you able to compare children who might have lost their parents by violent means as opposed to those who would have died, otherwise?
And again, that is exactly what we're talking about. Remember that, as I said, one of the triggers for complicated grief was how the death happened. If it was a violent death, if it was an ambiguous death where the parent was just reported as missing or dead and there was no body. And I'm glad you asked the question, Deborah, because you're realizing in this COVID-19 situation, people cannot grieve, people cannot have closure when somebody dies. They're not allowed to have a funeral. They're not allowed to have the ritual of closure. And for persons who have called into the hotline, that is creating a lot of stress, a lot of symptoms that would not necessarily have occurred if, let's say, they had an opportunity for closure. So complicated grief, yes, is a big risk factor for suicide.
Okay, thank you.
I see that some people have asked if I can share the PowerPoint, and yes, after the session, if you can just put your name and so all those who would like to receive it, I will share the PowerPoint with you. As I said, this is original research, especially on an adolescent population that is hardly listened to. Stacy, question?
Yes, Dr. Chatoor. Oh, Marisha, you want to go first? Okay. I know that you and Dr. Clay spoke about the age group 15 to 19 years of age as being one of the most vulnerable groups for suicide. However, recently, as a matter of fact, over the weekend, an 11-year-old male in Tobago attempted suicide. And I know we don't have clinicians only on this forum to see that we might have parents as well. So I just want you to just reinforce for those parents, because I don't want them living that, okay, what is wrong with this 11-year-old? Why isn't he in that particular age group that you actually just described? So I want you to probably just mention what are the vulnerable groups, because I know 15 to 19 is not the only vulnerable group that may commit suicide, and what are some of the reasons that an 11-year-old or children with that particular age group may want to commit suicide. So it's just to reinforce that, so that parents who may be on this session will be able to have an idea what to look for that particular age group.
Thanks, Stacey. It is quite interesting that as we're realizing younger and younger children are taking their lives. Last 2 years, we had a 7-year-old in Trinidad who took his life. And last year, I think somebody just before the SEA exam. So whilst my study focused on adolescents, remember, I also had interviews with the siblings of these adolescents. And that was not intentional. That came after the fact. Because here you had adolescents saying, Dr. Chatoor, my brother, my 10-year-old brother is feeling this way, or my younger sister. So I had to look at those younger age groups to see what was happening. So yes, you are correct. Vulnerable age groups are children as young as 7, and it goes right up to that entire adolescent period. And again, what is important here is that we have to monitor children when adverse circumstances happen. We cannot take it for granted that they're okay or send them out to play. or assume that they are all right. We must monitor what is happening, especially if the attachment bond was a secure one there with the parent who died. Any other questions? We just have about 2 or 3 minutes again.
I would just like to ask, if nobody else, what could TTAP do, like that situation with the mother who was just murdered with the 4 children? What sort of intervention is TTAP involved in terms of whether going to reach out to families, like through the ministries and so on, and make the association available for counseling like that? What is our position on that issue?
I don't know if you're aware, Jean, but from the 24th of March until now, we have had a hotline of 18 psychologists. Now, this hotline is available up to the end of July. It was 24 hours, and in August, when our clinicians had started to go back out to work, it's now from 8 a.m. to 10 p.m. Why I say that is that because of not only the mother who died, and I think we want to be very careful that we don't step on other people's toes, in that the Children's Authority has come on board and other of their providers. We are open to anyone who needs help, anyone who wants to talk. As you know, TTAP is not a financial institution. All of our services are provided free. So we have to be guided by what is being done, first of all, by the Ministry of Health, by Children's Authority, before we offer our services. But again, our services are there, available for all who need it. Now, I think we have to be very careful that we don't overstep what we do.
And those were good points, though, too. But I just wanted to just briefly hit, especially concerning with the children. For those who are on here who are parents, I need all to recognize that, especially the kids who are extremely young. Remember, they're so accustomed to having that connection and socialization with their friends, as well as other family members. But many of us, in the Caribbean, sometimes we might find, or if the child inside by themselves, they find we are here and them they're okay. You need to basically have your finger on the child's pulse, so to speak. You need to check for mood swings. You need to check to see if the child is showing any different, aggressive behaviors. Is the child doing any forms of self-harm? Self-harm isn't always where you can see it. Okay, so I need parents to, recognize that, such a thing as there's privacy, and then there is a point of, you have to do some checks. You have to do some wellness checks, not just only with yourself, but with your kids. You need to ask them what's going on, what's bothering you. If you can't talk to me, find somebody they can speak to. They can't always talk to you. Let them have another individual that they can speak to. And it's okay if your child has to speak with a mental health professional. I think it will actually help you in being able to cut off those steps where they make a choice that they can't come back from.
Mm-hmm. I would just like to add here that if you all go up onto our website, psychologytt.org, you would find a lot of resources to help you to deal with this COVID-19 also. As you know, there are videos out there, and I want to encourage you to access this. Now, I'm seeing on the chat that people are asking for the research and so. So just if you want more research on adolescent parental bereavement, just Google my name and my research comes up. All right, but I see a lot of you have put your emails in, and we will send out the PowerPoint to you. Thank you for that. As we close, are there any questions before we have a final vote of thanks?
Okay, Dr. Chatoor, good afternoon. I wanted to find out, in your research, have you looked at children who have lost their parents through separation? Because, sometimes one parent would not, if the parents has the child, or children would not allow the other parents to see or have the children interact with with the other parent.
Thanks for the question. As you know, bereavement is not just about or mourning just about a death. All right, so we can have children and adolescents who mourn the loss, as you said, they have separation. Divorce is a loss of parents who sometimes have Alzheimer's. You know, there are many, and all of these are losses that are not death related. And no, the study specifically looked at parental death, and I'll tell you why. There were lots of young men, especially coming into my practice, who were very angry, who were, and when you kind of unpack it, it is because they experienced a death, usually a father, and no one, and you're talking about men coming in at 19, 20, who at 13 and 12 had a death, and nobody never had a chance to speak about it. And I found that this was significant because many of them usually go on a step from the school into the jail. And I found that I wanted to explore this dynamic. And whilst I understand, Teresa, that there are other losses where children mourn, like divorce and so, that was not a primary factor in or variable in what I did.
Thank you.
Okay. Let me move a vote of thanks now, because I suspect that all questions have been stopped. I wish to thank Dr. Hazel Othello, Director of the Mental Health Unit at the Ministry of Health, who took time off today to join us to address us. Thank you very much, Dr. Othello. Our eloquent and erudite speakers, Dr. Karine Clay and Dr. Margaret Nakhid-Chatoor, who are members of our association, for imparting their knowledge to us and leaving us new information about suicide. To members who have shown interest in and have submitted articles for publication, many thanks. We encourage you even more. To anyone else who assisted in any way to make this event possible, I refer here to J.L. Valdez and Michelle McIntyre. Thank you for your assistance. And finally, all of you for attending. Let us take this information away with us and use it. It's invaluable. Remember to light your candle near a window at 8 p.m. on Thursday, the 10th of September, 2020, World Suicide Prevention Day. Don't forget, we continue our mental health virtual series on Sunday, the 4th of October at 5 p.m. to celebrate Mental Health Week. Thank you very much. Have a good evening.
Thank you all for coming. Take care.
Thank you.
Bye.
Thank you for a very inspiring presentation.
Yes, thank you all my peeps and from all over the world. Demetrius from England, hi. Nice.
Thank you very much. Thank you.
Nice to see you, sweetheart. How are you doing?
I'm good. How are you?
All right, and Demetrius is a psychologist in England. And Demetrius, now that you're onto our Trinidad page, be more visible if you can. Very nice. Nice to see you all those here. You all take care. Have a good one.
Okay, take care. Bye.